All right, let's get started. Good morning, everybody, and welcome to the session on ACHs in action, lessons learned, and looking to the future. My name is Bruce Goldberg. I'm a family doc and an independent consultant working with the ACHs, and it's my pleasure to be your moderator this morning. This is a really important session, and we have a fantastic panel. I'm going to introduce them to you in a moment, but first I want to remind you about some Zoom housekeeping. First and most importantly, if you're alone with Zoom, you're not. You've got almost 300 people with you today, so you're not alone. But the audience is muted and your video cameras are off, so we can't see you. You should only see the panelists and the slides when they are shown. If you've got technology issues, please put it in the chat. There is only the option to chat the panelists, not the entire audience. And our tech gurus will see your chats and we'll get back to you individually, also via the chat. If you have questions for the speakers, and hopefully you will, please use the Q&A box and we will do our best to get to you as many as possible. Both the chat and the Q&A function should be at the bottom of your screen down there on the little bar. We are recording all sessions and copies of all slides will be available on the website after today. And that's www.washingtonach.org. And now, most importantly, let me introduce our fabulous panel. First, we have Representative Eileen Cody. Rep. Cody is a neuro rehab nurse who was first elected as a state representative in 1994. And she serves as chair of the House Healthcare and Wellness Committee. And next we have Chase Napier, who is the Medicaid Transformation Manager for the Washington Healthcare Authority. We're also privileged to have joining us former State Senator Linda Evans Parlett, who is Executive Director of the North Central ACH, and that covers Chelan, Douglas, Grant, and Okanagan counties. And lastly, Allison Paulson, who is Executive Director of Better Health Together. That's the Eastern Washington ACH covering Spokane and the rural counties of Adams, Ferry, Lincoln, Pend Oreille, and Stevens. This session will really be a discussion, and hopefully we'll get that going across our panelists with time for audience questions at the end. So please remember to submit your questions through the Q&A button on the bottom of your Zoom bar. So let's get started. And I think the best place to start our discussion today is a reminder of how ACHs got started and what they were intended to do. So Chase, what was the HCA's original vision for ACHs and how were they created?
Yeah, thanks, Bruce. The first thing I want to say in response to that is we've been hearing so much of the progress regarding the delivery system reform and the 1115 waiver and DSRIP. And to answer that question, we really have to go back in time a bit. The ACHs started really forming in 2014. That's when I joined the Healthcare Authority about 6 years ago and have been working with ACHs from the beginning, really. And so we have to think, I'm going to speak a bit to the context outside of the delivery system reform and the 1115 waiver, because we really believed in the idea of ACHs before. And so it started with a couple of really monumental building blocks. And one of those was the State Healthcare Innovation Plan, developed really over the course of 2013. And one of the core concepts there was there's a lot of community capacity, but there isn't really a formal partnership regionally, and there's not as much of a partnership between state agencies and regional organizations, and specifically the need to bridge the gap between healthcare and community supports and community members. So that's where the ACH concept started to really formulate as a way to kind of formalize those partnerships across the community, across sectors, and with the state agencies, specifically the Healthcare Authority. The other thing was foundational legislation in 2014 that really spoke to the initial support for the concept and testing the idea of ACHs. So from the healthcare authority's perspective, there were a few things we really, believed in from the start. Authentic community engagement. We've been hearing and seeing some examples of how that's emerged in some of the testimonies over the past few days. The other one is really the neutral convening to support those clinical community linkages or addressing social determinants of health, however we want to frame that. And related to that, developing strategies to move investments upstream and the idea of paying for health and that health is local, health is more than healthcare. So we really recognized that and knew that we needed to partner in a different way. So ACHs for us were a regional partner, kind of a way to think bigger in terms of addressing health. And yeah, so that's kind of where it all started.
Great, thanks, Chase. So Representative Cody, what was the legislature's perspective on the creation of ACHs?
Well, the bill that Chase referenced was actually governor request legislation, and to go ahead and implement the plans, the Health Innovation Plan. And it was a pretty big bill. It had a lot of different factors in it besides the ACHs. The way I viewed the ACHs was a chance to really get the community more involved and drive out the data that we get in Olympia. We get a lot of data that we collect between the Department of Health and the Healthcare Authority, but it doesn't really get down into the community so that they know what their health problems might be, and they're different from different areas of the state. And so I really embraced the idea of the ACHs, thinking that would help drive out the information and get the communities focused on what they needed to change. As I said, it was that piece was not really, it was one of the smaller pieces of the bill because we had the all payer claims database in it and the Medicaid transformation. So I don't know that it had a lot of focus. It had some, is how I would phrase it. But I think that the bill got bipartisan support as it moved through the legislature. So because the Senate at that time was Republican and the House was Democratic. So that's the good news that we like to point to in Washington State, that we actually have done a lot of this together.
So speaking of doing things together, I think now we've got ACHs are up and running, and they've been up and running for several years now. So it would really be great to hear some examples of what ACHs are doing in their regions. And we'll start with Senator Parlett. If you could give us some examples, and then we'll move to Allison.
Okay, thank you, Bruce. And Representative Cody spoke about that bill 2572, a House bill. I voted no on that bill. It created 2 ACH pilots, but it was the other parts of the bill that I couldn't support. It was a very complicated bill. So anyway, I learned about the ACH a little bit more because I was asked to be on the board. My first board meeting was in July of 2015, and we actually went until after the 4th of July. The legislature got out very late that year, and we were discussing at our local NCACH what our SIM grant project would be. And we had a retired executive from Group Health, Peter Morgan, who was on the board, and he, of course, worked with new Representative Cody at Group Health, and his idea was to focus on whole person care. And I thought that was a good idea because we didn't know in 2015 if the waiver was going to be accepted by the federal government. But we did know that another bill that passed in 2014 said that all Medicaid contracts had to be fully integrated between physical health and mental health by 2020. So it seemed like a good thing to focus on since that was going to be a requirement anyway. So I'm going to rattle through a list of a few things we've done in North Central Washington just for the sake of time. And then I'm just going to add a little bit from one of the other ACHs, Olympic, because we're supposed to not just talk about our own area, and it's hard to keep track of all of this in my head. So we were second in the state in our region also to move toward fully integrated care. So we did a lot of symposiums helping those to follow us. We copied from Southwest. They helped us and we tried to help others. We've done a lot of convening and connecting partners, and we paid for a lot of trainings and technical assistance, working with different clinical groups, talking about empanelment and quality improvement, and bringing in consultants to teach them how and find out what was the best practice in our region so it could be copied. We did that with one of the hospitals who had a great process of calling people who were getting out of the hospital to make sure they were getting their medication, had they scheduled their next appointment. And it was so successful, we tried to spread that across our 4-county region. We did Narcan trainings, recovery coach trainings. We sponsored medication assisted treatment programs. So those are just a few. So let me talk a little bit about Olympic. Olympic had a huge effort to reduce the opioid crisis in their region. And what their efforts did led to a 52% of decrease of patients on high dose opioid therapy across their 3-county region. They also focused on oral health, something that we did not do in North Central Washington. And that led to the establishment of 2 brand new dental clinics serving Medicaid clients, one in Port Townsend, one in Port Angeles, and also a mobile dental unit launched by Peninsula Community Health Service. And lastly, Forks Community Hospital, due to the work of Olympic, saw a 50% reduction in unnecessary ED visits due to a new case management model they deployed. So the advantage of ACHs, I would say, is we're closer to the ground. We can see what the local needs are and just kind of work on what needs to be done in our own area. Thank you.
Allison, what's been happening out in your area? And Allison, we need to unmute yourself. There you go. Well, maybe not. Okay, Allison, we can't hear you, so I'm going to move to the next question. And I'm going to ask Senator Parlett. You mentioned that you were a state legislator. Now you're running this ACH, and the ACHs have to balance this sort of statewide approach, but also be responsive to the unique priorities in their area. Could you speak to that for a moment?
Sure. The example I would use is one of the required projects out of the 8 that we could choose from, with a minimum of 4 being required, was dealing with the opioid crisis. So every ACH, all 9 of us across the state, had to do something in that area. We chose, this is what we did. Because there were movements going on that were different, Okanagan County had a needle exchange. Grant County wanted to implement one, and Chelan Douglas County had a great group of people led by a prosecuting attorney, and people from all 4 counties came to the meetings. So we chose to augment rather than compete with what was already going on in that area. So some of the things we did, we established what is called a rapid cycle grant that people dealing with the opioid crisis could apply for. All across our 4-county region, different people did different things. For example, up in Tonasket, they wanted a drug take-back box. So they got the grant and were able to put one in. We also established a drug court in Chelan County. And there was support for regional learning, such as dental, pain care, and we had an opioid response conference. The opioid response conference was done in about 8 or 9 different sites all across our 4-county region, including Nespelem, which is, right there in the middle of the Colville Confederate Tribes Reservation. And we were able to stream in speakers from Western Washington, and then we broke into individual groups that were not filmed, and one of our staff from the ACH would facilitate those. It was very successful. In a small group, people shared their stories. So those are just a couple of examples.
Great, thanks, Linda. I'm just going to check back and see if we can hear Allison. Allison, you want to give us a word or two? Actually, it looks like Allison can't even hear me.
I
So-
wonder if she zoomed in on what Kathy sent to us this morning, which was different than the rest of the conference. Maybe Kathy can check.
Yeah, well, hopefully we'll have our tech gurus working on that. We're going to just move right along.
You're supposed to unmute her. That's what the chat says, Bruce.
Ah, I am. How's that? Allison, can we hear you?
Oh, and Diana says you can't unmute.
No. Okay.
I'm here, maybe.
Oh,
Can you
yes,
hear-
you are.
Yes?
Wonderful.
Okay,
Great.
my Leo-ness doesn't like to be muted.
So Allison, I'm gonna get you to catch up. I'm gonna ask you to comment on two things. One, tell us a little bit about what's been going on out in your area specifically. And then two, talk a little bit about rural healthcare and rural populations and how ACHs respond to that. Because you're certainly in a rural part of, many of your counties are in a rural part of the state. So if you could just talk a little bit about both those things, I think we'll get caught up nicely.
Absolutely. And I would just lead in with, I think Linda did an awesome job of laying out a lot of the tenets of work that is occurring across all 9 ACHs around our roles to convene and connect a really broad set of partners across multiple sectors. The amount of technical assistance and investments, especially in the Medicaid delivery system to get to integration, has really been critical across all 9 of us. The things I'd like to highlight from the Better Health Together region really has to do with the investment in our collaborative, oh goodness, sorry, I lost my screen here. The collaborative structure that we have put in place. And I think that really speaks to our interaction with our rural healthcare partners. So prior to the ACH forming, our critical access hospital network had really thought about and been funded through a HRSA grant to build a county-based health collaborative in each of our rural areas. And through a lot of leadership and good insight from those public health or public hospital administrators, they didn't just do sort of the narrow of, we should have the public health director and the behavioral health partner, as well as our primary care partners at the table. They really thought about who else needs to be at the table to make our communities healthy. And so included in that from the outset was county government, criminal justice, our social determinant of health partners, the faith community, and so forth. So BHT was really aided as we started to think about this broad transformation work by that model already being built out in our rural communities. So we have spent a ton of energy in not only ensuring that our primary care and behavioral health partners had what they needed to move into integration, be ready for value-based payment, and increasingly their motivation to try and actually improve the health of their patients was growing, and their ability to start to have different kinds of conversations with our housing, our food, and transportation partners. BHT has worked really hard to ensure that the entire Medicaid delivery system was part of our waiver efforts and have been in contract with probably 95% of our behavioral health partners in the region and 98% of our primary care Medicaid providers in the region to really address these key integration, opioid, care coordination, chronic disease management work overall. This past year, we have dug even deeper into our set of work in helping to fund some connection point between housing, food, and transportation partners and primary care and behavioral health. So really kind of going that next level down into how do we not just have, we all agree we need to be working together, but really forming those partnerships to move forward. Additionally, we've really raised up and taken seriously our mandate to address health disparities, and both as a board and an organization, as well as with our partners, have been on quite an equity journey that includes over 70 partners taking our organizational equity assessment. We are just finishing up our third cohort of Equity 101 training. So 120 folks have gone through a set of training activities that are really getting us to some common vision about what addressing equity in the region looks like. I am so proud of the partnerships we've built with our rural healthcare providers, and I think we've been able to offer through the waiver enough flexibility in funding for each one of those health systems to be able to make investments that really aligned, one, with what their community need was, but two, also how they see themselves playing in this complex world as it both relates to rural health, but also value-based payments. We're fortunate that our county commissioners in our region, partly because of their role prior to integrated managed care, they were deeply engaged in behavioral health, but I think mostly because they're really good leaders who are committed to their communities, have been active participants in how we build out not just healthcare infrastructure, but how that infrastructure connects out to solving community challenges. So we see some great work around the criminal justice system, certainly around workforce development and economic development.
Great. So I'm going to bring Chase and Representative Cody into the conversation. Let's start with Chase. So Chase, you've heard a lot about what ACHs are doing. How does that fit with the ACH vision for the state now?
Yeah, I think, we've gone through a lot of reforms and initiatives over the past few years, but that's ramping up still. Our paying for health, kind of the value-based concept is just going to continue to move forward, and it's just a huge priority for HCA to achieve outcomes, the paying for health strategy. So in that, I say that because the idea of what I mentioned earlier, it just reinforces it, that ACHs through the community engagement, the authentic community voice, getting that feedback, getting the community partners to work together, and the collaboration across sectors, the healthcare system and the social supports and services. All of that just becomes, even more important as we get into a more kind of advanced value-based environment and a paying for health effort. So I would say the ACHs are more important now than ever. And the other thing, that I would say in terms of the ACHs going forward, we've seen the capacity and the partnerships working, and not just in the context of district. I think what Allison just said, she hit on so many different ways that the ACHs are connected to local initiatives and efforts, and it spans just every sector, it spans every community, and we see that. I've been in local meetings, a handful of meetings and over the years, and hearing firsthand community leaders saying, and this is even before disrupt, before the 1115 investments, just hearing and saying, we're partnering in ways that never happened before. Just kind of these ahas and these light bulbs of, we can work together on different strategies. And the reason I think that doesn't happen is because the convening function is so unique, and the bringing people together and the capacity to do that, and having the resources and some of that flexibility to do that. And not be focused on a specific program or focused on a specific deliverable, but really focused on just that function of helping partners work together and trying to achieve outcomes. That's what the ACHs provide. And we see that. So I think that's something we're committed to. We want to see that continue. We don't want to see that collaboration and that capacity to decline. And it really is unique to the ACHs. So yeah, I just say it's ongoing, a very important function for the future.
Great. So Rep Cody, we hear a lot about the need to transform our healthcare delivery system. What's your view of the ACH model, and how does it fit into how the legislature is thinking about healthcare transformation for the state of Washington? And Rep Cody, you need to unmute.
Always forget at least once. they've played a great role in so far in transformation in the mental health and medical integration, because that's been a long time in happening. We did it over several years, but now we've got all of our mental health and physical health integrated, which I'm very happy about. That was one of my goals. And so we've seen that. And then now that I think the next steps will be on value-based purchasing and trying to help lower the cost of healthcare and deliver better healthcare for less is really what the goal that we have to have. So I see them playing a role there. I will say, I'll do the cautionary legislative comments that the money is only through, well, this year, hopefully getting another year extension because of COVID, which I think is totally fair and that will happen. But the idea is supposed to be that they were self-sustaining by the end of their pilots. And so I know that that's something that will be brought up in the legislature, and especially under the current fiscal constraints that we've got. So that's my probably one of the worries that I would have, and I want to pass it on to everybody so that they can worry too, because we definitely need to figure out how that's going to happen. But I do believe that they are showing their value, and that the local community along with the state should be able to help fund it.
That's great. You actually foreshadowed our next couple questions, which are really to focus on the value or the successes. Let's spend a couple minutes talking about two things. One, kind of the value and the successes. And then secondly, I think what you alluded to, Rep. Cody, which are some of the challenges. So, Allison and Linda, and we'll start with Linda. Could you share some more examples of key successes that have happened, and then we'll have Allison do the same.
So there's been a lot, and I've mentioned some already. We've created 2 Oxford houses in our Port County region. We recently have hired a recovery coach coordinator. He has real experience having been recovered himself. COVID has slowed down the next step, which means working with people getting out of jail, because at least the Chelan County Jail, people aren't letting anybody in to work with anybody. But there's a whole big, we're really excited about thinking if we can work with people, help them transition when they're getting out of jail back into society. We partnered with Collective Medical to expand that platform across our medical practices. With COVID, it's changed how we operate. We use a lot of Zoom all the time now, and we have found that, I'll give an example, our whole person care collaborative meetings or our transitional care and diversion meetings, now that we're using Zoom, our staff has trained themselves to get into smaller groups. So those people who normally don't speak up at a large meeting, if there's only 2 or 3 in a Zoom meeting, they contribute. And then when they go back to the whole group, we're hearing from everybody rather than just those who are most vocal. That's been a real plus. Also, we have huge issues because of our size. Okanagan County is the frontier county in the state of Washington. Broadband issues are real, transportation issues, not enough community care workers. But with COVID, we do have more telemedicine and things like that. We know we need to help some of these providers, but there's just been a lot of successes besides just convening meetings.
Great. Allison, what about from your perspective? And you need to unmute as well.
Okay, here we go. I'm
are.
on both phone and computer. It's a little complicated for my simple mind here. There are a number of successes that I would highlight, and I think you will see these successes in other ACH regions as well. So one is, and you got to hear a lot about it yesterday, is really our partnership with our tribal nations and our Urban Indian Health Center. I think that has been a really, really critical set of partnerships, and the ability to offer some additional funding to support that, I think, has really bridged what was a legitimate divide in our region. What's been beautiful about how much time and what a 6-year extension would give us is it actually takes that amount of time to build a deep enough relationship and be able to show that what you say is what you're going to do, and have then some of that doing result in the next phase of conversation. So I know that's true with a number of regions across the state. Another great success, I think, for our region has been that in September, our city council voted to fluoridate our water, providing a really important public health intervention at a time where we see health disparities growing and growing. I will stay off of my stump speech about this, but had we not had the Medicaid waiver funds available, and had we not sort of teed up this idea around what is whole person care, I think it would have been incredibly hard for us to sort of muster the collaboration, which included not just oral health providers and medical providers, but housing providers, and other community leaders, especially like our NAACP and some of our local Latino community leaders, to come forward into that. So you get kind of a double win of, one, finally community water fluoridation in Spokane, largest city in the state of Washington, to not fluoridate its water. But two, it really showed how deep the set of partnerships that ACH has been able to build overall. I could keep going, but I'm trying to manage myself.
You're doing a great job. So Senator Parlett, what about some of the challenges?
Well, the Medicaid transformation project, the waiver, is complicated. I mean, I think the first year being executive director, I could hardly tell anybody what I did because it was so complicated. I mean, the special terms of conditions and kind of saying you can't have more than 51% on your board of clinical providers. So lots of challenges. I would say in our area, and the board was formed before I was on the board, we need more community voices on our board, more community-based organizations. We know that, and we are still in our strategy session, you know, planning ahead. So the future state of North Central ACH has not been determined yet. I won't be there. I'm hoping to finish at the end of next year. I committed to 5 years after my unexpected death of my husband. I mean, I wasn't even going to stay in this job, but it's, I have to be honest, it's helped me emotionally, but it's also invigorating to think that you really can make a difference at the local level. And so it's been fun. The lack of guidance, I would say, and unifying vision at the state level, whether it's community information exchanges or community-based care coordination, we kind of waited to find out what the state was going to do, and we learned there isn't going to be one vision. That's complicated. And then I would say just competing priorities. You can have all the money in the world, but if you don't have the time to do whatever, it's going to be a problem. I mean, just think about it. We're talking about integrated care. We're talking about workforce development. We're talking about value-based purchasing. Now we're talking about a primary care model. There is so much going on, and these are all the same people that we are working with. So we're very sensitive when the state asks us to send out another survey saying, just a minute. I mean, we just kind of be very sensitive to not have survey exhaustion. So lots of challenges, but everybody's just plowing forward to do the best they can. And I think we're successful, all 9.
It's great. So Allison, from your perspective, what are some of the challenges you see? And you need to unmute again somehow. There we go.
This is crazy. This is like my first Zoom meeting, so apologies to everyone.
I don't believe that for one moment. Nice try.
You know, I think that one of the challenges that is really ahead of us, and the ACHs are well positioned to help deal with this, is the need for the cross-sector collaboration. And that we have often identified that there's this amount of funding in behavioral health, or there's this amount of funding in primary care, or in housing, or in food. None of it gets to the interconnecting, or no one is funded to make these connections across sectors. And I think if it was just a mandate from the state or the feds to do that, we think, gosh, that would make it easier. But I think it's actually a lot deeper. And this, how do you build out the set of partnerships across sectors so that you really do learn to speak the same language? And it's probably creating a new language that understands each of those challenges. I think that we have seen a lot of possibility, but we need more flexible funding. And I think this is where a year 6 gives us some additional flexibility in that way to sometimes just pay for the time that it takes to figure out how to have those conversations and negotiate those data agreements, those shared care compacts of how you're going to work together. And, one of the challenges is we all are going to have to let go of some of the control, and that we've got to figure out how you build out those accountabilities across multiple partners and having a structure in that way. The final thing that I would say that we're thinking a lot about is how you get the best use of a dollar, and whether it's a healthcare dollar or a housing dollar or a county dollar, that the complexity of each of the sectors that are playing right now, oftentimes I think sort of has people throwing their hands up and saying, well, we could fund it with this, so we're going to. And we're not really getting that leverage. And so I think when we talk about bending the cost curve, whether it's in healthcare or it's in criminal justice or it's in education, that we've got to get a better value. Part of the challenge is how do we start to define that type of work and having the right infrastructure in place to be able to do it.
Thanks, Allison. So Chase, what do you see are some of the challenges from the Healthcare Authority?
Yeah, I agree with what's been said. I think what really resonates is the many initiatives that have been underway. We've learned from other states and from our experience, building the ACH partnerships and capacity takes years, and it took years. And we did that while we were implementing, an 1115 delivery system reform waiver, while we were moving forward with integrated managed care across the state, and while we were advancing our value-based purchasing roadmap, among other initiatives and other local efforts. And so there's just a lot going on, and all good, all positive, but it's a lot of competing priorities at the same time that I think have made our work, our kind of environment pretty complicated. And then, yeah, I think, challenges going forward. I agree with the need to continue to bring together the multiple sectors and, figure out how to create that alignment. There was a mention around kind of the vision and the unity across the state. I think that's something we're figuring out how to better partner with ACHs on, and other organizations. I think as state agencies, that's going to be really important. It's a challenge, it's difficult, but I think we have some of the partnerships and the mechanisms to do that more effectively. We've learned, from our experience, kind of where there is a need for that balance between that local perspective and that uniqueness that really does apply to the communities, to the zip code level. But there's also some of those opportunities where we can avoid, kind of replicating, and we can learn from each other and lessons learned. We can try to find those economies of scale, try to replicate models that work. So I think that's all on the radar for the future. That's some of what we want to talk about, with the idea of the extension year, if we do have some additional time and to use these resources and work with ACHs. That would be one of the things we would want to talk about, is how do we really set up that partnership and move forward in a little bit more unity and kind of drawing on lessons learned and making sure that whatever is unique and kind of local is because it's necessary, and similarly, whatever really needs to be statewide and really needs to have more shared commitment from state agencies and across our ACHs and partners, that we also advance those areas of alignment.
Great, thanks, Chase. So Rep. Cody, you responded to the challenges before. I think you mentioned the big one, which is funding and the environment we're in. So there's some great questions coming. I'm going to move us along a little bit and switch to the next question, which Rep. Cody, why do you think the state needs ACHs?
Well, I would say with all the discussions about building relationships, that's not done from Olympia. It really does have to be done at a local level. And when I think about the response to COVID, especially in Eastern Washington, where their outbreak was later than what it was in Western Washington, but it really took the local perspective to help bring that under control. So I think that's probably one of the biggest advantages that the ACHs have been able to show. And actually, I would remind Linda of when we started rural healthcare tours when she and I were co-chairs in the House. And it wasn't the first one, but it was one of the early ones where we went to Winthrop and we had a meeting of the providers there. And it was the first time that they had ever really all been in a room and got to know each other type of a thing, which think about that now, Linda, they're doing it all the time. So that's just one of the advantages, I think, to know that people are working together because they're taking care of the same people. So it's definitely much more important. It's easier to pick up and call somebody if you know them than it is to call another professional that's a total stranger. So I know that from experience. Definitely, I think that's one of the big things that has been advantage. And I see when we talk about the problems, I think it's the struggle between local control and the state mandates, and that's always going to happen with everything. It just some days goes one direction a little bit more, and the next time it goes the other. So, but we just have to learn to work together and figure out how we can move forward on that.
Thanks. Chase, what about your perspective from the Healthcare Authority about why the state needs ACHs?
Yeah, I mean, I've spoken to that, so I won't repeat kind of the functions that exist with ACHs that we need going forward, but a couple, I guess, different elements. We haven't talked as much about the line of sight that ACHs provide in the local communities. That's something that the state just can't replicate. We cannot have the same line of sight and the same community engagement. And even I think we've learned a lot about how community engagement doesn't work and how getting the community voice in the mix doesn't work. And we've really leaned on ACHs to help lead that and learn and navigate. And we need to figure out how to really leverage that and bring the community voice into decision making, into just informing the delivery system reform work, the ability to address social determinants of health, like all of that requires that community voice and authentic engagement. So there's a line of sight that ACHs can foster and have learned. So I think we really need to lean into that. And as we talked about, this whole symposium, the focus on health equity, I mean, that's a huge piece of it. So the other thing would be working across programs. We've hit a little bit on that, but I think we need to have conversations, I think, across state agencies and with ACHs, and they represent a broad array of partners, about Allison's point of how are we more effective, how are we most effective, how are we utilizing these resources to the best of their ability, and the regional coordination function and the partnership between state agencies and ACHs and their communities and partners. There's just, I think, a really unique opportunity there that we've probably only scratched the surface on. So yeah, that's another one I would call out.
Great, thanks, Jay. So we have 15 minutes and some great questions have come in. So I'm gonna ask one more question, then we're gonna turn to the questions that are coming in. So my last question, I'd ask everyone to just give a couple sentence answers so we could get to the rest of the questions, is what should the future of ACHs look like, and what role should ACHs play going forward out into the future? And gonna start with Senator Parlett.
So I think in the future, they should cross sectors more, try to figure out what the social determinants of health. All 9 ACHs are trying to work on a model that would create a social investment funding model. That would mean changing the contracts with the MCOs. It's a big thing to tackle. We need to continue to talk about that. We've already established the trust in our regions. I think we can learn so much from each other. The 9 ACHs connect every Wednesday morning. To learn, I have 4 other ACHs bordering North Central ACH, North Sound, King, Greater Columbia, and Better Health Together. To learn from Greater Columbia that they're doing this internship for behavioral health interns, that was really special. And all that we've learned from Liz at North Sound about targeted universalism, othering, belonging, making us think more about equity. I mean, this is just like being a legislator. If you love to learn, you learn so much from other people. The biggest challenge, I think, is to make sure that the state and the federal rates for Medicaid work for everything that we're trying to do. That's going to be a continual struggle, but if we can focus, I think we're headed in the right direction.
Great, thank you. Allison, your thoughts?
It's what Linda said, and I would add that, as BHT's really thought about its future, it really is delving deeper into solution making, and that us existing in this first 5 years was partially because people wanted the money that we had governance authority over. Like, let's just not kid ourselves. I have a very charming team, but with the kind of funds that we had available to do really good work, folks were coming to the table. I think there has been a really important sort of connecting of not just intellectually how we solve things better together, hence our name, but really like what are the mechanics of being able to do that? So I think the future of the ACH is really being a solution maker. And I think part of that solution making is being good partners to our state agencies as they think about, we need to accomplish this for the state. And there isn't the ability to dive deep from a state agency standpoint into individual communities. But each of the 9 of us really have that set of partnerships and information to help really start that negotiating, maybe small end negotiating about how we serve the complexity of an urban population and a frontier population. And I think the ACHs are really well positioned to have started that. And we need to keep pushing ourselves to figure out how do we bring that local community voice to the table, and how do we work proactively so that regions are really well represented as we work with each of our state partners. The other thing that feels really important to note, and we've just barely touched on it at all, is we talk about the Medicaid waiver and the Medicaid healthcare delivery system. There is no way for that system to get better health outcomes and bend the cost curve until we have a more robust connection to all of the other things that keep people healthy. And so the future of the ACHs is really how do we bridge that gap? And it's not getting Medicaid to pay for every other need that they have. But again, it goes back to how are we bringing all of these different funding sources into a community and trying to get that best dollar available. And I think the 9 ACHs are really well positioned to have built some competence in doing that through the Medicaid waiver, and that could be expanded moving forward.
Thanks, Allison. Chase, your thoughts about what the ACH's role should be going forward?
Yeah, I again agree with what's been said. I would guess another way of answering that is one assumption we don't have is, this delivery system reform focus was really unique, and I think going forward it will look a little bit different, and I think that's okay, and I think we have the ability to really draw upon the partnerships and the coordination opportunities and the work that Allison mentioned with state agencies. And I think it's going to look a little bit different going forward, but the functions are still relevant, the ACH's ability to kind of look across those communities and work with the various sectors, and kind of it's a way to bridge the gap. I used to think of it as it's like an orchestration role that ACHs play across communities, across sectors, and then also between the state and communities. And it's just a really unique kind of multidimensional way that they can function. So not necessarily with the same 1115 district resources, at least not forever, but the ability to partner is still so important, and I think will be something that we continue to lean into.
Rep. Cody, your thoughts about the future?
Well, I think all of these three have said it pretty well, but what I'd say, I'm impressed that the terminology of social determinants of health, both Linda and Allison mentioned that. And I think that is the future. And the encouraging thing is that the managed care organizations, the Medicaid managed care, are all talking about how to use social determinants of health. And so I see the role of the ACH as being the bridge between all of those different Medicaid managed care organizations and the community that they represent, that to really focus on social determinants. It's great that people are finally realizing that if you have a house over your head, you might be healthier, or if you have food on the table, just those little things that I thought we all learned Maslow's hierarchy of needs back in the day when we were in school. But it's interesting that it's taken us this long to try and bring it in really into the delivery of the healthcare system. But I think that really is the value added that the ACHs bring, that they can really deliver on.
That's great. You really, again, touched upon the next couple of themes I wanted to talk about. The first one, the thing, you just mentioned it, Rep. Cody, but we hadn't talked about it a lot, is the relationship between ACHs and the managed care organizations. And so I'd look to Linda and Allison, if you could just talk for a moment about the relationship between ACHs and the MCOs in the state. Let's start with Allison this time, and because we've been starting a lot with you, Senator Parlett, we'll give you a break.
Thank you.
Well, I think in the BHT region, we have 3 integrated managed care organizations, and then of course, coordinated care provides support to our foster care kids, that we have worked really hard to build both collective partnership and individual relationships with each of the managed care organizations. We're also really clear that we're not going to get in between the relationship between the payer and the provider. Those contracts are really theirs to negotiate overall, and that we really see this role in more of an what's in the best interest of the community. And in the places we need to push, as we were moving through the integrated managed care, we heard from some behavioral health providers, this isn't going quite right. Because we had an established relationship, they knew we weren't coming, sending them on a wild goose chase, but really could look at, okay, well, how can we solve that problem? So I think we played an important kind of brokering role in that. Increasingly, that conversation is really turned into, I would say, almost a 3-legged stool conversation about community-based care coordination, about behavioral health access, and how we link social determinants of health together. And we see from all of our managed care partners a real willingness to try and figure this out. I think there's a really large gap in just all of our working knowledge across how the 3 sets can work together, where there's flexibility in contracts, where there's business strategy playing out, and how can we broker that together. I would highlight that BHT secured the contract with Commerce for the Better Health Through Housing contract, which really was looking at high utilizers of the ED who were also experiencing homelessness. We added into that contract a model to try and develop a reinvestment fund that could help sustain efforts like this overall. I was delighted to see our big healthcare systems in Providence and Multicare, as well as Molina, CHPW and AmeriGroup come to the table with our community action organization that was helping to facilitate the care coordination portion of this. And in earnest, we have all been working to try and figure out how can we share data, how can we get to total cost of care and total cost of intervention, and at that point really have a sense of what a reinvestment strategy might look like. So we see good effort and intent coming from our managed care partners. And I think, you know, as this goes along and we get behavioral health and primary care integration complete, we'll be ready to move on to the next set of challenges that we've identified.
Linda, Senator Parlat, your thoughts about ACHs and MCOs?
We have 3 managed care organizations in our area, and we will have 4 as of January. And first of all, we had some meetings early on with the MCOs. We had a big one scheduled at the beginning of this year with one of them, and the weather didn't allow the plane to get in, and then COVID hit. So we have just restarted those meetings, and I give a lot of credit to the lead for our Whole Person Care Collaborative in setting them up. We had one not too long ago. I participate, and I learned who was in this. It happened to be Melina, who was in charge of all of the transitions out of jail, one person in the state. So I connected that person with our new recovery coach. I think we can learn from them. I think what Allison said is true. There's a lot going on that we just don't know about, and it's a time. So we are scheduling regular meetings now to continue to educate each other and find out how we can help and how they can help.
Great. Thank you, Senator. Last question. Chase, this one's for you. What is the HCA's vision for how ACHs can be sustained?
Yeah, it's a good question. You know, I think on the short term, we've talked about the extension. I think that's going to be, you know, it's going to give us a little bit of an on-ramp to sustainability. The other thing we're still working on with ACHs is just where is there that shared alignment around the functions. And I've talked about some of them, but I mean, those conversations are ongoing with ACHs and within the Healthcare Authority. And we're going to be talking to other state agencies as well about, you know, where those values have really played out and where we see them. And so we don't have I'm not going to say we have a funding plan. I think you know, I'm not the decision maker on that, and we have authorizing environments. But what I will say is I think those functions have established themselves. I think we've been hearing a lot about that over the past several days and in this session. And I think the investment to support ACHs is reasonable and feasible. I think we're going to figure it out. I think we have the mechanisms to keep ACHs around. And like I said on my last response, it doesn't necessarily mean we're going to see the $1 billion you know, investment over the next 5 years in the delivery system reform through ACHs. I think the future, you know, is going to look a little bit different than the unique opportunity we've had with the 1115 waiver. But I do think that those functions will be sustained, and we're working with ACHs now to kind of map that out. And yeah, so I think we're gonna figure that out together, and we have a little bit of time to get it all mapped out.
Great, thanks, Chase, and thanks to our panelists. What a great discussion. I think you know, we learned a lot about how HCHs began, what they're doing, their importance, relationships in the state, the future. And, you know, I think particularly one of the places we didn't get as much into, but hopefully another day, is the issue of social determinants of health. That was clearly a theme that was emerging as we spoke, and something that's certainly going to continue. So really fantastic job. Really thanks to all of our panelists, and thanks for our hundreds of friends out in the audience who joined us. As a reminder, there's a recording of this session, and related materials will be available on the ACH website by the end of this week. So look for that. And now we will take a 15-minute break before the closing speaker. It's great closing speaker who you're going to have. So please take a break, but come back to hear Nicole Maher, who is the president and CEO of Group Health Foundation, a longtime advocate and leader in health equity. And I can assure you it's going to be a fantastic wrap up to the day, and that Nicole is likely to challenge us all to do a whole lot better than we're doing now. So hope you'll stick around, and her keynote begins at 11 a.m. So thanks everybody. Have a great day.